Hi, everyone, and welcome to our 2021 Self-Direction Virtual Conference Series. My name is Casey DeLuca, and I'm the Director of Membership and Conferences for Applied Self-Direction. Thank you so much for joining us today for this session, the VA Update on Veteran-Directed Care. I'm going to run through just a few quick housekeeping issues before we begin. You can submit your questions and comments at any time during the session by using the Q&A pod in the lower left-hand corner of the Adobe Room. If you experience any audio or technical issues during today's session, you can send us a message, again, by either using that Q&A pod or you can email us at info@appliedselfdirection.com. I'm excited to introduce our speakers for today, Pat Brady and Dan Sheps. Pat Brady is a managing consultant with the Lewin Group, where he works with both the VA and the Administration for Community Living on the Veteran-Directed Care Program. And Dan is the National Program Officer for all the long-term care services purchased by the VA, including the Veteran-Directed Care Program. So with that being said, I will turn things over to Pat to get us started.
Thank you so much, Casey. It's great to be here with you all. It's been a couple years, but we're so thrilled to be here today to talk with you about veteran-directed care. Before I get started, just a big shout out and thanks to Applied Self-Direction for having us here, for all the education that you provide to VA Medical Center, to the network here. And we're always thrilled to speak with you all about veterans and veteran-directed care. So we had a couple polls. We're always trying to figure out exactly who our audience is going to be. How comfortable are you with veteran-directed care? How much do you know about veteran-directed care? Even if you think you know everything there is to know about veteran-directed care, I at least find that I'm always learning something new. So our content, our message today is intended to reach everyone. So whether or not you're in that 78% of folks who come from and are working with an operational veteran-directed care program, that could be a VA medical center, it could be a VISN. I see a number of you in the participant list. It could be our critical FMS providers who are providing critical support to veteran-directed care providers, as well as to veterans and their family members, as well as our VDC provider groups. So those AAAs, ADRCs, Centers for Independent Living, and state units on aging. So there's about 80% of you here who come from an operational VDC program, 22% who do not. And then just looking at our grouping here. So 37% from an ADNA, those are who we would classify as likely a VDC provider, or maybe an ADNA who's interested in learning more about veteran-directed care. 25% of VA medical centers, 25% of attendees are from VA medical centers, another quarter from FMS, and then a host of others, including veterans and their family members. And we want to thank you for being here today. So let's talk about what are we going to cover in our in our time today, in our 56 minutes left. We're going to start by covering veteran-directed care, an overview, background, important policy updates that are critical for you to know. We're going to start with that. We're then going to spend some time presenting evidence and research that's been shared through a series of educational webinars, through other types of resources that are available publicly that showcase why this program is so valuable. Valuable to VA medical centers and VA, but most importantly valuable to veterans and their family members who want to live independent lives, who want to remain engaged in their homes and communities, who want to achieve goals that maybe they haven't been able to achieve in some time. And veteran-directed care can be this tool, this powerful resource in order to accomplish that. So we're going to present that as well. Then we're going to talk about growth and outlook. Our goal here is to continue to grow access to veteran-directed care across the VA healthcare system. And Dan's going to talk about ways in which we can do that and some of those drivers for growth. And then, of course, we want to spend some time with Q&A. So we'll make sure to carve out as much time as we can for that today. So Dan, I'm going to turn it over to you to spend some time talking about veteran-directed care, what it is, and some background on the program.
Patrick, thank you, and Casey, thank you, and Applied Self-Direction for having us today. We're very glad to be here, and I'm honored to talk about the Veteran-Directed Care Program. The program began in Battle Creek, Michigan in 2009. The program was at that time and remains today a strong federal partnership between the Veterans Health Administration and the Administration for Community Living. VDC, Veteran-Directed Care, is modeled after self-directed services, relying strongly on the cash and counseling demonstrations, but modeled after the self-directed programs available through the Centers for Medicare and Medicaid Services, CMS. Now, this does not mean necessarily that we follow all of those rules and individual states have for their Medicaid programs. Some of them we do, some of them we don't. Obviously, where states have rules that require direct care workers to have workers' compensation, we follow that rule, definitely. There are some states in their Medicaid programs that do not allow family members to be workers. We don't follow that rule. We follow, the VA allows family members to be a veterans worker in this program. VDC is available at 69 medical centers, VA medical centers, and is provided through or by over 200 providers in 36 states, plus the District of Columbia and Puerto Rico. 60 of those 69 medical centers have really active programs. Active meaning they routinely make referrals or make authorizations to the program. We currently have enrolled 3,400 veterans, and we'll talk about enrollment in just a minute. This is kind of how it works. Part one, VA medical centers purchase veteran-directed care from Aging and Disability Network Agency providers. We do that through a mechanism called Veteran Care Agreements. This is a non-contractual mechanism that is allowed by the Mission Act, which is the governing statutory authority for all of our purchase care programs, whether it's transplants or home respite. It's all covered under the Mission Act, and that sets forth the eligibility for VA's community care program. VA medical centers will assign a veteran who has been referred to, generally to the VDC coordinator. They will assign that veteran a monthly case mix budget that is based on a case mix instrument which we've borrowed from the state of Minnesota, and we use in both this program, not for budgeting purposes, but we also use it for our Homemaker Home Health Aid, our agency program for personal care services. VDC serves veterans of any age who are at risk of admission to an institution. For the veterans in VDC, they receive a service budget, which they can use to hire family, friends, neighbors to provide long-term services and supports to them, largely personal care services. There is also an elaborate process to determine if certain goods can be purchased through veteran-directed care as well. The veterans also critically receive assistance from the ADNA through a person-centered counselor and financial management support from a financial management services organization, critical pieces for how the program works. Veterans determine how to use their budget, hire, schedule, direct, and fire their employees. These 4 types of agencies: area agencies on aging, ADRCs, centers for independent living, state units on aging. These are our primary providers of veteran-directed care, and they are listed as eligible providers both in the statute, the Mission Act, as well as in our enabling regulations. That's an important point, that the Aging and Disability Network is part of VA statute as a set of entities that VA can purchase long-term services and supports from. Before we go into business, so before we sign a medical center would sign one of those Veterans Care Agreements with an Aging and Disability Network agency, we perform a readiness review to ensure ourselves that the ADNA has the skills and competencies to deliver veteran-directed care to veterans. That's conducted both on the program side as well as the financial side, and that is a contract that we have with the Lewin Group to perform those readiness reviews on our behalf. There are different groups of veterans that we have found over our 12 years of existence do really well in veteran-directed. I'm not quite so ready to call them target population, although Patrick is. But veterans who have mandatory eligibility for nursing home care seem to do particularly well in the veteran-directed care program. That's important, and let me just draw that distinction for a moment. Veterans who are enrolled in VA for their health care have eligibility for home and community-based services through what we call the medical benefits package. So home and community-based services, including veteran-directed care, part of that medical benefits package. There is a subpopulation of those veterans, who are enrolled in VA for their health care, who have mandatory eligibility for nursing home care at VA expense. And this could be care in a VA-operated nursing home called community living centers, or it could be a private nursing home, which VA has a contract with, called community nursing homes, or it could be at a state veterans home. Almost all states have at least one state veterans home. I believe there are 150 of them nationwide. So that subpopulation is made up of veterans who are highly service connected. So they have been rated by our benefits office as having a service connected disability at a 70% level or higher, or require nursing home care for their service-connected condition. So this is the population that we are particularly interested in, and you'll see in a little bit why. We're particularly interested in keeping those veterans out of nursing homes. Number one, because by and large, veterans don't want to go to nursing homes. And number two, this is a mandatory expense. So we want to do whatever we can to keep them at home. Veteran-directed has proven to be, when it comes to personal care services, the most effective mechanism we have in keeping veterans out of nursing homes. And it's a major selling point for us. Veterans do well in veteran-directed care when they have above average personal care needs. Basically, the tipping point, depending on where you live, is between 20 and 25 hours a week of personal care services. You need 20 to 25 hours a week of personal care services. You're going to get a better deal. Medical center is going to get a better deal if you choose veteran-directed. Veterans who have frequent and avoidable hospital, ER, or nursing home admissions and days of care, we've done a very good job there. Veterans who live in rural and highly rural areas, there are a lot of veterans who live in rural America and highly rural America, and there aren't agencies out there. There aren't home care agencies out there, or not many of them, and they're always booked. And veteran-directed has been able to step in and really serve that population effectively. Patrick will speak to that more in the next segment. And finally, veterans with complex conditions, ALS veterans, veterans with Parkinson's or spinal cord injured, due to the fact that whether it's the veteran or the veteran's representative, they can really design an individualized service plan for that group. We've had remarkable success in veteran-directed in caring for ALS veterans on ventilators at home, which is really where they want to be. And it's a very important mission for the program. And that's generally where where we want to start, when we start a program, we want to start with difficult cases to be able to show what we can do. Okay, well, this is like everything in one slide. Let's start with the veteran, as we always should. The veteran, as I mentioned earlier, is assigned this, it's expressed as a monthly budget, but we've really got to move away from the notion of month-to-month budget and think in terms of global budgeting. This is the budget for the authorization period. The authorization period for veteran-directed is 365 days, and that's the number that we're working with. And that budget, that veterans budget, serves three things: personal care services, other services, emergency backup, some planned purchases, some goods. Now, the majority of veterans, the majority of veterans' budgets goes towards labor and labor-related expenses. It's like 97.5%. And the rest is goods. It's very important that we think, and as we're developing a spending plan, to get to in a minute, we're developing that spending plan with the veteran, or as a veteran is developing the spending plan, to look beyond just the immediate needs of the budget, of the month, and to look to the extent the veteran can of what they want to accomplish during this period with their budget, and that really comes to a head, and it's a major change from what we've done in the past. When it comes to emergency and backup services, we have at least one folder of angry letters from veterans who said, "I saved too much money. I put too much aside, and now it's gone." And so those old days where we had the planned savings, those days are over. You can have the planned purchases, in that broader look, but we're not coming to the end of the authorization period, and you find this large excess, and then, well, what are we going to do with it? And then try to come up with something to spend that money because it was authorized. Well, VA is going to look very dimly on that at the end of the year. Those are going to get denied because that's something that should have been planned for all along. So we really have to move out of the thinking we had done with that past, the month-to-month setting, too much aside, and really be much more active with that. On the administrative side of this, the administrative really begins, and we'll talk more about this later as well, is a one-time assessment. That's critical. That's like the critical piece that distinguishes veteran directives. Well, I guess you'd have to say so to the employer authority. But this is the key, that this person-centered planning, and that is what's so unique to veteran-directed and all the things that we do in VA. This is the one place where person-centered planning, person-centered care really is embedded in what we do. There are administrative costs of the program. There's the FMS fee, and there's the ongoing counseling. But the ADNAs are in this unique position here. They will know the veteran better than just about anybody in that VA healthcare world. Perhaps the primary care provider might know that veteran as well, but I mean, the ADNA is in the home, or was in the home pre-pandemic, knows that veteran, knows what their goals are through that process of person-centered care, person-centered counseling, and that's so unique, and it just doesn't happen elsewhere. And we'll talk more about this. Is not the only time we're going to bring that up. Okay. Well, who are the veterans that are in the program? We've talked about some of the diagnoses that we focus on, and the fact that they tend to be above average in terms of ADL needs. They are younger. They are more service connected and more highly service connected, and more of them live in rural areas compared to veterans in our agency-based programs. 50% of them are under 75, which is remarkably young. 1 out of 3 is in that priority group 1. Those are those highly service-connected veterans that have that mandatory nursing home access. Over half of them live in rural areas. Now, the veteran population as a whole is more rural than the average U.S. population. But even within that, this is a rural group in veteran-directed. Part of that is the wisdom of those rural medical centers who've said, gosh, we need to be able to, these folks need access to care, and this is the best way to do it. 66% of veterans have an authorized representative to help them manage or completely manage their veteran-directed care responsibilities. And the average spend per unique veteran in the program is about $26,000 a year. It costs us $103,000 a year to keep a veteran in a nursing home. Who works for veterans in the VDC program? Veterans have, on average, 1.8 workers, and the average worker works for 122 hours per month. So I guess that's about 30 hours a week. This data is a couple years old. Average salary was $14.60. I'm assuming that that's higher now. 64% female, which is a much lower percentage than I think if you look at agency workers in direct care are much higher percent female. At least half of the workers are related to the veterans, and the majority work part-time. Okay. Did I skip a slide there? No, I did not. Okay. I just missed the button. Okay, there are two things I want to point out here. And Patrick in the next segment is going to touch on this in much greater detail. We have sky-high levels of satisfaction in this program. This has been carefully studied a number of times. In fact, we have a co-author of one of the studies on our call here today, Merle Edwards-Orr. And it's really that first quote, if you look at the block, that top block on the right, 100% of veterans and caregivers report being able to choose who provides the care and control how they want services done. This is a key point that comes across over and over and over again in all the studies. Choice and control. And, you know, these are veterans who are having a very difficult time physically, medically, but it's even more important that the independence, the ability to choose and control what's going on in their home, in their life, is critically important to them. The major complaint we have about the program is that we don't let enough veterans in the program. And that's from veterans who are receiving it now. They say, oh, we know lots of people who really need this program, but they can't get in. The flexibility that the program offers is unique. It's very different for VA, but really important. We have excellent reduction in inpatient utilization. You can see those small charts at the bottom right that where you have, I'll just focus on the ones with the red circle, which is a nursing home. That chart on the left looks at before the intervention of veteran directive, a high degree of nursing home use compared to a similar matched group of veterans who were receiving homemaker home health aid for the first time. And then a year after the intervention, huge drop in nursing home use, an actual increase for the veterans in agency care, but just remarkable finding. Okay, and here we are growing. You look at coming across from the left where we were in April of fiscal year 19 at 3,000 veterans, up to perhaps 3,300 at the end of the year. Then in 2020, in the pandemic, not only holding our own, but by the end of the year, increasing. We had 17.7% increase in unique served in the program in the middle of the pandemic. And that had a lot to do with the veterans choosing, with the VA making it available, and then our AD&A partners being willing to take on new veterans in the middle of the pandemic and all the chaos that we have gone through. And then solid numbers so far this year. We expect to reach 5,000 uniques by the end of the fiscal year. So I'll stop here and turn this over to Patrick.
Thank you, Dan. We're going to transition just a little bit.